Hello and welcome to today's event, Meaningful Use Updates and Strategies 2014 and Beyond. Today's session will review recent changes to Meaningful Use Stage 1, Meaningful Use Stage 2, measures, and the impact of recent changes on the ED. My name is Kristen Monsey. I'm T-Systems Marketing Specialist, and in just a moment we'll be joined by our presenter, Dr. Robert Hitchock. If you have any questions that you would like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We'll gather these questions and try to address as many as time permits at the end of the session. If we don't get to your question, we will follow up with an email to you one-on-one. We will have a recorded version of this session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who was unable to attend. I will distribute the recording of this event to all attendees. Dr. Hitchock uses his unique expertise as both a physician and IT expert to guide strategic decisions for T-Systems solutions around key industry topics like meaningful use and ICD-10. He has over 20 years of experience in healthcare and more than a decade as a practicing emergency physician. And now to kick off our presentation is Dr. Bob Hitchock.
Good morning, everybody. Thanks for taking time out of your schedule and joining me. We've put together a webinar series that's going to run over the next several weeks dedicated to meaningful use and the many aspects of the recent changes, and provide you some opportunity to understand more about the rule, which is today, discussing interoperability and meaningful use, particularly around the consolidated CDA and some of the new requirements in Stage 2 of the connectivity between multiple systems, as well as strategies for helping to connect with a patient. That'll be our next on September 25th. We'll also then talk about using multiple systems for meaningful use, so that's using a T-System EDIS, let's say, and an HIS solution, but more than one certified solution for meaningful use on October 9th, and the challenges and opportunities that presents. And then later in October, we'll discuss very specifically how to use EV41 for both meaningful use Stage 1 and Stage 2, where we'll do an in-depth dive into the feature functionality around our certified version of EV and how it relates to each one of those measures. Today, I want to get through a few, many things actually, but want to talk about some things that the recent rule, the 2014 rule has done. It's changed meaningful use as it was defined previously in a few very important ways, and that's universal to anybody playing the game. There were some Stage 1 changes in that final rule as well that we do want to discuss. We'll talk about quality measures. Stage 2 in particular, we'll go through those measures in a relative amount of depth, and then we'll talk about what this means to the emergency department. We'll run through those webinars again and provide some links so that you can have some additional information to help you get through this thing called meaningful use. As we begin this, I think it's very important that we have a common understanding about some terminology. When we speak about meaningful use, there are stages and years. And in many cases, they're used interchangeably when in fact they are two very, very separate and distinct concepts. So a year concept for hospitals is the federal fiscal year running October 1 through September 30th. And what happens during a year is not necessarily what's required of a particular stage. And when I say that, so for instance, Stage 2, the earliest Stage 2 can start for a hospital is this year, 2014, this coming federal fiscal year, but it's not mandated by that. So there are certain things that happen based on a year calendar and then other things that are required by stage. And so I'll be very particular about mentioning year or stage in certain cases and do want to call that out. So for 2014, October 1st, 2013, here in a couple of weeks, all the existing 2011 certification expires, and then only 2014 certified software can be used for any stage of meaningful use. So this is here where the year and the stage are disconnected. You must start using 2014 certified software for any attestation that you're doing for meaningful use from October 1, 2013 on. There are also some meaningful use program changes which we'll cover that take effect this October regardless of the stage of meaningful use that you're in, and that affects everybody. Stage 2, of course, is the next phase of meaningful use. It is a new set of measures, both core and menu. Hospitals will be required to meet stage 2 measures 2 years after being successful with stage 1, unless you were one of the really early adopters of meaningful use, and then you actually get 3 years. But the earliest that anybody's going to be subject to stage 2 is in a month, provided there are no delays. And that will only come after a minimum of 2 years of attempt and or success at stage 1. So if you are in your first year of meaningful use presently, or just completed 90 days, let's say, you do not start stage 2 in October. You actually will start stage 2 in October of 2014, not 2013. So you'll be also in stage 1. So what changed in the meaningful use final rules based on 2014? Well, first thing is that clinical quality measures have changed for everybody. All hospitals, regardless of stage, must use quality measures from the stage 2 final rule. Now, all the stage 1 measures are still in there, but there are additional ones. So there's an opportunity now to choose your quality measures a little differently in 2014 and not be mandated to use what was described in the stage 1 rule. Clinical quality measure reporting also becomes electronic, although we do not believe that CMS will be ready to accept these electronically. However, that is the rule as it stands today, that hospitals will need to report their clinical quality measures. There will be one electronic submission from one certified system. This is important because when that happens, hospitals using multiple systems, which we'll discuss in the October 9th webinar, hospitals using multiple systems must get all of their data into one in some way, shape, or fashion. There's a variety of things that have been that the stage 2 rules address to help with that. The most important thing for 2014 is that no hospital has to report for the entire year. Now, normally, all other things being equal, hospitals that are past their first year of meaningful use, first year of stage 1, would have to be consistently gathering data and attesting for the 365-day period of the federal fiscal year. Because the government was delayed in getting the rules out for 2014, that is not the case. So between October 1, 2013 and September 30th, 2014, a hospital that is not in their first year of meaningful use will only need to report data for one contiguous calendar quarter. That can be October, January, all the way through the end of September. So pick a calendar quarter that works. And the reason for this is this actually allows hospitals now to get on the 2014 certified software. It allows the vendors to have the time to get their software certified. And this is a really, really good year for that, for hospitals then during this time to start looking at how they're going to start meeting stage 2, even if they're going to be in stage 1 for 2014. If 2014 is the first year of meaningful use, it's still 90 consecutive days. So subtle differences, 90 consecutive days versus one calendar quarter, but everybody gets a break. So what changed in stage 1 in the stage 2 final rule? Even though titled stage 2, it did have impact to stage 1. Effective this current year, federal fiscal year 2013, the exchange of clinical information measure, that's the CCD, has been removed as an element. It was too confusing, too poorly described by CMS, and they were having a very, very difficult time figuring out how to audit it and get hospitals to understand it, and it just became too much work, so they threw it out. There are CPOE denominator changes to stage 1. These, however, are optional for anybody in stage 1. Stage 2 has changed the denominator for CPOE from unique patients to counting individual medication orders. Hospitals are allowed in stage 1 to adopt that new denominator if they choose to. There's probably not much reason to for a hospital. It's much more complicated. However, the hospital may choose to get a view into what their stage 2 success might be like. And tell you, so for instance, in our certified product, you can actually run the CPOE report using both denominators. So although you may choose to attest using the easy denominator of unique patients, you may want to run reports and track how you're doing on all medication orders, even in stage 1, to give you some planning for stage 2. And we'll go into that here shortly. Vital sign. There were some vital sign denominator changes. Those are optional for the current year, but mandatory as of October 1. Those are subtle. The height, length, and weight measurements change from patients 2 and over to all patients. So this will have a clinical impact. We need to have the clinicians understand that they need to be measuring and weighing all patients, and that information needs to be documented regardless of age. Blood pressure, instead of being 2 and over now as a requirement, is now 3 and over. That corresponds very closely with recommendations from societies such as the American Association of Pediatrics. There is a new Stage 2 measure called View, Download, and Transmit, affectionately known as the patient portal. As of October 1, the Stage 1 measures of electronic health information and electronic discharge information have been replaced by the requirement to have a certified View, Download, and Transmit solution. What that means is that presently in Stage 1, you can provide electronic discharge instructions and electronic health information to a percentage of patients that ask for it. Most patients don't know about it and don't ask for it. Therefore, the denominator is very small, and you can be very selective about how to meet that measure. Basically, you're in control. As of this year, those 2 measures must be met by the View, Download, and Transmit, and in doing so, you must provide 50% of your patients online availability of their medical records within 36 hours of discharge. So we're moving in Stage 1 from an on-demand, retroactive, if you will, kind of request to a proactive provision of information, and it also will mean that Stage 1 hospitals will need a certified patient portal. This is a big difference. So even if you're in Stage 1, as we talk about patient portal, take an interest in that, because that actually does, the Stage 2 patient portal now is relevant to you as well. They formally removed clinical quality measures as a core element, but you still have to report them to get your meaningful use money. So although it's not a line item anymore, it is still a requirement. So that's just a change in terminology. The clinical quality measures, there are 29 now clinical quality measures for hospitals. They have to choose 16 of those. They are broken down furthermore into 5 categories. You have to have at least 1 from those categories. And again, all the 2011 CQMs are included, although the measure logic has changed slightly. Clinical quality measures also, we can see them morphing. They're becoming increasingly aligned with other things that hospitals already have to report on, such as PQRS, value-based purchasing measures, IPPS and OPPS, those types of things. The idea is that within a couple of years, you'll be reporting once for multiple programs, and clinical quality measures will cut across all of those regulatory programs. What the ability to choose now 16 to 29 does is it can reduce or eliminate the need for reconciliation between multiple systems, in that you can choose clinical quality measures that can only be fulfilled in an inpatient environment, or only be fulfilled in an ED environment, such as ED 1, 2, and 3, and then pick some of the clinical quality measures related to discharge medications from an inpatient status. Really helps to eliminate or significantly reduce all that worry about getting data between systems. The biggest difference between Stage 1 and Stage 2 is defined in the final rule. Stage 1 continues that clinical quality measure accuracy is totally irrelevant, and you can report zeros if that's what your certified system tells you. That is unchanged. However, in Stage 2, it is expected that you are producing accurate numbers from your certified system. The vendors will all be certified to be able to demonstrate accuracy, but you will also, during your attestation in Stage 2, be signing a statement that says that you believe that these are accurate. There's a big difference from Stage 1. So for those people moving into Stage 2, what does it mean? Well, if you're on 2014 certified software, which you'll have to be as of October 1 for any phase of meaningful use, those software solutions will support both Stage 1 and Stage 2. The vendors certify to only one list of certification measures. Those certification measures then have a crosswalk table where they can be used in Stage 1 or Stage 2. So the vendors may certify to 35 different measures, and those measures will be related to stage 1 and or stage 2. So your by 2014 certified software means you can use it for any stage. In future years, the same thing. As we get to stage 3, it'll be 2016 certified software, and that will support stage 1, 2, and 3. There are still the idea of core and menu items in stage 2, so you still have mandatory and then optional items. Everything that was in stage 1 has either been removed because it was reached a maximum threshold, and or it was moved to required. There's one exception to that, and that's advanced directives. We'll go through that. That is completely unchanged from stage 1. Everything else is either still there but required, or has been deprecated. So the measure changes, some of them have been eliminated. A lot of them have thresholds that have raised or have been, the menu items have been moved to core. This is great because you've already either had experience with them or have the ability to understand what your current success or not would be, even of the menu items that you're not reporting. So in many cases, you will have knowledge of how you will do in the future based upon your past. There are some that were then modified, consolidated, grouped a little bit differently, and then some new ones, besides the new and exciting stuff. This is an opportunity to look back again at your stage 1 performance for the menu measures that you didn't attest to, and see how you're doing. Run your reports, take a look, what do your numbers look like? Those are going to be required in stage 2, so you can get a glimpse into where your potential deficits are, and you can do that today without really having to worry about or doing it outside of your formal process of determining what measures you're going to meet, how you're going to meet them, but it'll give you a great opportunity to go back and take a look and see how you're doing. Okay, so stage 2, meaningful use. The core set of elements use CPOE, and we'll talk about those. It's 60% of med orders, 30% of lab and radiology. Demographics, vital signs, smoking status, clinical decision support. These are all familiar, I think, from stage 1. CDS is a little changed. EMAR is a new measure. Online access to records is view, download, and transmit, or the patient portal. Med reconciliation, you'll recognize as a menu measure from stage 1. That's now core. Saving lab results, running a patient list report, and providing patient-specific education. So in this list, there's really only 2 grossly new measures. That's EMAR and view, download, and transmit, and we'll go into each one of these, like I said, in some degree of detail. Additional summary of care. This has been modified from stage 1, but still the same general concept with a little electronic transmission added. Reporting syndromic surveillance, immunizations, and reportable lab results, all those public health reporting options. Now, instead of being required to do a minimum of one of them, as in stage 1, you're required to do all of them, but they're still really the same measures. And then we've got, in the measure set, we've got advanced directives, and I'm sorry for not having this broken out this way. Advanced directives down are menu set items, so reporting advanced directives, e-prescribing, which is new to the hospital environment, access to diagnostic images and results, recording family history, electronic progress notes, and then providing electronic lab results to ambulatory providers. And like I said, we will touch on every one of these here very shortly. Let's start with measures that were eliminated. In the final rule, they talk about their goal in how they're going to manage measures from one stage to the next is that any measure that meets a maximum threshold, and right now that's proposed to be 80%, will be eliminated in the next round or the next stage of meaningful use. So you will not see in stage 2 medication list, allergy list, or problem list as individual elements. However, you're still required to document these because these are required elements in the Consolidated CDA. The Consolidated CDA is an electronic document, if you will. It's an electronic file structure of a document that is the basis for the summary of care and the patient portal view, download, and transmit measures. CMS does define that meds, allergies, and problems are mandatorily included for the hospital to get credit for sharing information with the patient through the patient portal. So it's still going to need to document those, but they're not called out as individual threshold elements. We can expect that in the future the same thing will happen, so anything that's at 80% for stage 2 will likely be retired in stage 3. And then, as we discussed, the electronic health information, electronic discharge instructions were eliminated, and they were moved to a new element called patient portal. Measures that are unchanged, there's only one, and that's advanced directives. Recording of advanced directives on admitted patients 65 and over remains a menu or optional item, and the threshold remains 50%. If that's something you chose for stage 1 and you were successful, bingo, you've got one of your 3 menu items for stage 2. There are 6 in total. You have to do half of them. There are several measures that just underwent threshold changes. So things you already have experience with in stage 1 that now just have a raised threshold. Vital signs. There's that subtle denominator change we talked about where you just need to start recording a height and weight for all. Smoking status is up to 80%. There are 2 new smoking choices as well, light and heavy smoker, and the cutoff for that is 10 cigarettes a day. Demographics at 80%, and then saving lab results or incorporating lab results at 55%. So these are the same numerator, denominator, with the exception of the denominator change for vital signs, but essentially they're all still unique patient for vital sign, unique patient for smoking status, unique patient for demographics. And really all that's changed is your threshold. So you will be able to know what your success will be in stage 2 based upon your stage 1 success. There are several items that really their main change was to go from menu to core. Patient education was one of those. It went from menu to core, but the threshold remains the same. And you'll see this theme. When they move something from optional to core, they keep the threshold the same generally. They just now mandate it. So still low, 10% threshold on that one. A med reconciliation, which is at the bottom, has been moved to required now. The threshold remains the same, 50% of inbound transitions of care must have med reconciliation done. Patient education is unique patients. Then all of the public reporting measures have been moved to core. Those are reportable labs, immunizations, and syndromic surveillance. The other changes for stage 2 on this is that you must have successful and ongoing transmission. You do have exclusions available in rare circumstances. If there is no ability, if there's no one to receive that information, you will get an exclusion. That is generally not the case. If you are in such a rural area that connectivity with the outside world is limited or makes this very difficult or impossible, you can also apply for an exclusion. But for nearly every hospital, be prepared to have successful ongoing submission of this information. Very important to note for these measures, though, however, what is not required. It is not required that every patient or every lab have a transmission of information. It is not required that it happens from every certified system with every piece of data related to that patient. What you must show as a hospital, very simply, is that you have at least one ongoing submission of information about immunizations, information about syndromic surveillance, and information about reportable labs from your system, or from your hospital in one certified system. That means that, let's say that you're using T-System EV, and you're using your enterprise EMR. And you have immunization information in both of those. You're perhaps giving a tetanus toxoid in the emergency department, you're giving pneumonia and influenza vaccinations to inpatients. It is not required that the tetanus toxoid information and the influenza and pneumonia vaccination information get transmitted out of both systems for you to meet this measure. Not to saying that that's not the right clinical thing to do and the right thing to do for the patient, but to meet meaningful use, you would only need to establish one ongoing successful transmission of information from either the HIS or T-System EV. Other measures that have been modified, enhanced, or consolidated, and here's where things start to get interesting, where we start having to do a little bit deeper dive into these measures. Clinical decision support, really what happened here is they moved it from 1 clinical decision support rule to 5, and they've lumped in here drug-drug and drug allergy interaction checking. So you do not see drug-drug, drug allergy as individual line items. They are included in clinical decision support. So you need to have 5 rules on, plus drug-drug, plus drug allergy interaction checking in any one or more of the certified systems in your hospital. So as long as you can attest and say that in your environment, you had on for the entire reporting period 5 CDS rules, drug, and drug allergy are set. You could turn on drug, and drug allergy in System A and clinical decision support rules in Systems B, C, and D if you chose to, as long as together in certified systems you meet the total sum and they were on for the entire reporting period. All right, summary of care. Summary of care, summary of care contains 3 different individual things that have to happen in order to meet this measure. The first is very, very similar to Stage 1. You need to provide some sort of summary of care to a downstream provider. This can be, as it was in Stage 1, electronic transmission, email, fax, snail mail, printed and handed to the patient. Doesn't matter as long as you can say that somehow some summary of care was available and provided to a downstream provider, even through a patient or some other mechanism. The threshold is up to 80% of outbound transitions of care with anticipated follow-up, aka a discharge, of course. And it's important to remember that the summary of care measure applies, all 3 of these apply only to outbound transitions of care, so only to discharges. And that's relevant because in Stage 2, you're allowed to continue to choose the all-ED patients method or the observation method of determining which patients you're going to put in your meaningful use calculations. If you choose the observation method, that means that you are counting all inpatient discharges plus all ED patients that are admitted. Since summary of care applies only to the discharged patient, this could only be met by your inpatient system if you choose the observation method. So your focus on summary of care under the observation method should be exclusively on the system or systems that are used to discharge your inpatients. So similar to Stage 1, you've got this sort of just make sure that there's a summary of care provided. Relatively straightforward, very flexible in how you do it. Now comes the second portion of the measure, which is entirely new for Stage 2, and this is that you must provide an electronic summary directly to the next provider. The denominator for this, again, is the outbound transition of care. The threshold is 10%. It can come from 1 or more certified systems, so you can, on your discharges, send from any number of certified systems to get to that 10%. Thankfully, 10% is pretty darn low. You must electronically provide that summary of care directly to the next provider through a certified system and in a method that vendor is certified to. There are a couple of different methods. There's one called direct. That is it's a point-to-point encrypted email. It's a mechanism of transmission that's very secure. It was actually designed by the Office of the National Coordinator, and all vendors are required to certify to the direct method. When we go into implementing and going through these Stage 2 measures in future webinars, we'll talk about the fact that direct means that your receiving entity has to be enrolled by your direct provider. Basically, they have to sign up. They have to be validated. They have to have security certificates, all this kind of stuff, so that you truly know when you're connecting to Dr. Jones down the street, A, that is Dr. Jones down the street, and that B, that everything is secure from sending to receiving. There are other mechanisms of transmitting electronically which will meet this measure, which vendors can optionally certify to. So you need to know not only that your vendor is certified in summary of care, but what mechanisms of transmission can you use based upon their certification. This is one of the very, very much, I think it's the only measure that comes to mind that I can think of, where you are actually required to do something in the way that the vendor was certified. There is a very broad statement from CMS that says that you don't have to use the system in exactly the same way that your vendor is certified, that you're allowed to modify things yourselves and have your own workflows so long as you're using the functionality, but you don't have to use the same that detailed approach that your vendor did. This is one of those that's really not the case. You must know how your vendor was certified and use only that for, or use only the certified capabilities in their system. So far we got two elements to meet the summary of care measure: providing some summary of care in some fashion, providing 10% electronically and directly to the next provider, and then you must show that you have the ability to connect to an EMR system that you don't own or operate and that is different from the sending system. So that means that you basically will need to connect to another ambulatory system or another hospital system that you don't own and that is different. CMS does plan to have a test system available for you to connect to that, once successful, you can attest that you've met that measure. This is a do it once and you're done. It's not ongoing successful submission like the public reporting measures. This is just show that once you can connect to a disparate system outside of your organizational control. CMS, as of yet, does not have that system up and running. They are still eliciting vendors' input. They're actually looking to get a consortium of vendors together to either design a system or to make their systems available in a test environment for CMS, but it's not set up as of yet. CPOE was changed significantly for Stage 2. Much like when Stage 1 was first released, a lot of people read or thought of meaningful use as CPOE, and the other measures kind of fell by the wayside until they sat down to really understand it. Well, CPOE is still a huge focus in Stage 2 because they've changed it so dramatically. So the first thing that they did was they added laboratory and radiology orders to medication orders as those that are required for CPOE. Each one of those has their own threshold. You must meet those thresholds individually. Your denominator is not med orders plus lab plus radiology and a threshold of meeting the combination of those. You must meet them individually. The denominator is also changed now, where you're actually counting each individual medication, laboratory, or radiology order placed in your facility, including those on paper. So your denominator is all orders placed on the patients that you're counting for meaningful use. So that's either ED patients that were admitted and placed in observation and all inpatient discharges, the observation method, or the all ED patients method, where you're counting all emergency department patients plus all of your inpatient discharges. What we do know is that even accounting for all of the ED patients, the inpatients with an average length of stay of somewhere between 4 and 6 days, the number of orders, so just the individual count of orders in the inpatient environment, tends to be significantly higher than that in the ED environment. The threshold for medication orders now, so if you count meds between your ED and your inpatient environment, the threshold is that 60% must be placed in CPOE. That is now unlikely to be met in the emergency department alone. That was a very viable strategy for hospitals using the unique patient denominator for Stage 1, is to roll out CPOE in one environment, inpatient or ED, and they could meet that threshold. It is unlikely now that most hospitals will be able to meet the 60% medication threshold with a CPOE system in the ED only. They may be able to do it in the inpatient setting only, particularly using the observation method. However, as we know, CPOE implementation and adoption in the inpatient environment has been the most difficult for hospitals. So hospitals without CPOE in the inpatient environment should definitely take notice of the new denominator change, start looking at their order distribution in their facility, and make aggressive plans to roll out CPOE in the inpatient environment. Similarly, with laboratory and radiology orders, the denominator for each one of those is, for both of those, is a count of individual lab orders and radiology orders. And those are defined by CMS. I mean, radiology is basically anything that uses emitting radiation or ultrasonography. Laboratory is basically anything that requires a laboratory to run. It's really the orders that you would think they were. 30% threshold, however, is a little bit different. For most hospitals, they can get to a 30% threshold with the all-ED patients method and CPOE in the emergency department. But since they're not getting med orders there, it's unlikely that a viable strategy for a hospital is to fragment their approach to CPOE with focuses in one area or the other. So it really is driving CPOE implementation throughout the whole hospital. To place those orders, it continues to be that it must be placed by a licensed individual. It must be really the first instance of the order in the medical record, and it can't be acted upon prior to entry in CPOE. Protocol orders do count. There's some discussion in the final rule about how a hospital can choose not to count protocol orders if they'd like to, and I'm not sure why anybody would do that, because it gives a far more flexibility and more likelihood that you're going to meet that measure. So nothing's really changed about what orders qualify for CPOE. The big change is the denominator, which is going to drive CPOE implementation throughout the hospital, and the fact that you now must meet thresholds for medication, laboratory, and radiology orders independently, but meet all three of them in order to qualify for the one measure called CPOE. The new core measures, EMAR. You must record medications with EMAR that has assistive technology, which essentially means barcoding. You must track all doses that are in a particular order in order to qualify. The denominator for this is the number of medications ordered, and those are ordered electronically. So the number of electronically ordered medications. The numerator is the number of those medications for which all doses were tracked in EMAR with assistive technology, and the threshold is 10%. There is an exclusion here. Hospitals with an average daily inpatient census under 10 are excluded. So a vast majority of your critical access hospitals are excluded from this measure. The thought behind that being that given an extremely low volume of patients, that the burden to the small hospital of implementing this type of system from cost and process change would not yield the benefits that it would in a larger facility. So critical access hospitals, take note, average daily inpatient census under 10, you do not need to do EMAR. With a threshold of 10%, a very, very low threshold, if you have EMAR with barcoding implemented in your facility in the ED or the inpatient environment, you should be able to get to 10% easily. I don't think there's a need for most hospitals to look to put it in all environments, unlike CPOE. View, download, and transmit, the patient portal, brand new to stage 2. It says that you must provide the patients the ability to view their information, download it, or send it off to somebody else. The denominator here are unique discharged patients. So again, once we look at, when we look at summary of care, this really applies to the discharged patient only. Now, unlike summary of care, you could provide a patient that was seen in the ED, admitted to the floor, and discharged from the floor. You could provide them access to their ED records and not their inpatient records, but still qualify by providing that unique patient access to their medical records and some information to look at by giving them information from just one venue of care. I know it's a little confusing, so I'll let you, if you need to, re-listen to that or ask a question on that a little bit later. There are two elements to this that must be met in order for the hospitals to meet the view, download, and transmit. The first is that 50% of patient records must be available online within 36 hours of discharge. This really means you're either going to be forcing your docs, if you have bad docs out there that aren't locking records, you're going to be forcing your docs to lock their records in a timely fashion, or you are going to be putting preliminary information out on the patient portal. And that's something you should probably take back to your facility and look to say, at 36 hours, where do we stand on record completion? Additionally, 5% of your patients must actually get on, view, download, or transmit their information. You are now responsible as a hospital for your patient's behavior and how they interact with their healthcare information. We can discuss in more depth in future webinars, but there are ways to do this. One potential option would be to make it part of the discharge process when patients are discharged, particularly from an inpatient status where you may have a little more time, is to take a few minutes show them the patient portal, get them enrolled, have them do a username and password, and log into the system and look at their medical records. Therefore, you are easily going to capture 5%. But this will mean that you're going to probably have some new processes in your facility. Additional new measures, most of them are in the menu set. Recording family history. This is a unique patient measure, same as smoking status, vital signs, all those. Basically says that the denominator is the number of unique patients, and the numerator are the number that have any record of a medical history of a first-degree relative. The threshold is low, it's 20%. Many times you'll find that you're collecting this information currently. If you are, then you're probably going to get way past your 20% threshold, and this would be a good menu item for you to look at. Another new menu item is electronic notes. This is also a unique patients measure. The numerator are the number of unique patients who have a progress note generated electronically. CMS does not define what provider generates this progress note. It could be a nurse or a physician, and the same flexibility has been given to the vendors. The threshold is only 30%. For folks using our system in the emergency department, I would hesitate to say, I mean, most situations, 30% threshold is something that you will already meet because 30% of your unique patients have their notes being generated electronically in the EV system. And in most cases, I think inpatients systems, if the nurses are using that to document their clinical care, will also meet this. So this should be a freebie for hospitals that have robust systems in place for stage 1. It's almost impossible not to have electronic progress notes in some way, shape, or fashion with all the other things that have to be documented already in stage 1. So I don't think folks are going to struggle with that either. Other new measures, e-prescribing. This is true e-prescribing, generating prescriptions electronically and transmitting them electronically to the pharmacy. The threshold is 10%. The denominator for this is the total number of prescriptions provided at discharge. So again, this will relate to if you choose the observation method and you want to do this measure, you have to do it from the inpatient discharge or at the time of inpatient discharge. For those using the all-ED patients method, the majority of your discharges will be in the ED, and you can look at this. Electronic access to radiology results is access to the actual image without logging on or selecting the test in PACS. The denominator for this is the number of radiology studies whose result is one or more images, and the threshold is 10% of those must be available to be selected in your system. If your enterprise system is certified in this, which we believe that all enterprise systems will be, you are almost assuredly meeting this threshold of 10% by the fact that all you have to do is really basically hook those two up. And then if you do perform lab tests for ambulatory providers, if they are electronically ordering directly with your lab, you send back 20% of those results electronically to that ambulatory provider. You can meet the another menu item called providing lab results to ambulatory providers. This really has nothing to do with inpatient or ED care. This only applies to ambulatory providers who are electronically ordering directly with your lab and utilizing your lab for those tests. That covers the measures for stage 2. At the end of this, I have a link out to a CMS website that you can get to from the presentation. And we'll also make sure that it's on the Meaningful Use page on our website. That will get you to a master list of all these, and you can click through then to a PDF which goes into great detail about how to calculate the numerator and denominator on these and the details behind them. What does this all mean for the emergency department? It's a little different perhaps than stage 1 in how hospitals may or may not choose to use the emergency department. You still have the choice, choosing to use all your ED patients or only look at those that were admitted or placed in observation. None of that has changed from stage 1. You do have the new CPOE denominator. That really means CPOE is most likely going to be everywhere. It almost assuredly will have to be in your inpatient environment, but probably everywhere in order for you to be successful, and certainly by stage 3. The higher thresholds mean the greater potential impact of adding your ED visits in if you have high success in your ED system or lower success in your inpatient system. looking at that all-ED patients method to meet those higher thresholds may be something that you really want to sit down and take an early gander at and see how that will affect. And the low thresholds really look to one system. So you can either utilize or not your emergency department to really help drive some of those EMR radiology results, e-prescribing, patient education, all very low threshold items, and you can look to one system or one area of care where you really want to focus on any process change that might be necessary to drive those. It's very probable that you're probably going to need to get your ED records into your patient portal. You would certainly may want to. It's the right thing to do clinically, but also to help to get to that 50% at 36 hours of discharge. You may have much better compliance with getting records completed in your ED than you would from an inpatient physician or from physician discharging an inpatient. If that's the case, then you look to connect your consolidated CDAs out of your ED system. And in general, with everything we looked at, there's very little clinical impact to your ED. You're not really altering the lifestyle of your clinicians in the emergency department, unless, of course, you decide to go with e-prescribing as your menu measure and are introducing that into your ED. So I've talked nonstop for way too long now, as is typical with me. I hope that you've gotten most of what I said. We have the ability, we're going to go to Q&A here in a second. In the meantime, please keep in mind that we do have some upcoming webinars, and if you haven't received the invites for those, you can go ahead and contact us and we'll send them back out to you. Please feel free to join. The great thing about registering is that even if you can't make it, you will have an opportunity to get that recorded version for later viewing. And then lastly, we're going to put these links out, links to the Stage 2 measures, and again, those have click-throughs to PDFs with a great amount of information about how to calculate those measures and what it means to the hospital, a list of the Stage 2 clinical quality measures, the frequently asked questions page at CMS. It's a little difficult to navigate. They've got a lot of stuff on there, and it's not always tagged the greatest, but do root around in there if you have specific questions. CMS, of course, being the source of truth on these, is a great place to go. If you can't figure it out, go ahead and email us here. We'll send it out, and very often what I try and do is respond with verbiage taken from a source of truth, whether it be a CMS FAQ or the final rule. There's a link to the ONC Certified Healthcare Product List, so you can check all of the products in your environment as to whether or not they're currently 2014 certified, and a link out to our 2014 certification. I did that to the CCHIT website just because it's a little easier and cleaner to read, but we are also on the ONC Certified Healthcare Product List. So questions. At this point, I'd like to open it up to questions. If you do have questions, please submit them in the Q&A, the question, and we have them starting to roll in, so I'm going to go through those. We've got about 12 minutes or so left. I'm willing to take all that time, and I can stay really as long as the questions keep coming. If you think of a question either after this or you want to ask the question more one-on-one, go ahead and email those out to a contact that you may have here at T-System. If you don't have a contact at T-System, go ahead and email me. It's Hitchock, BHITCHCOCK @tsystem.com, and we will go ahead. You can also get a hold of us on our website. There's a contact page there. Go ahead and put that in, and there's an area to speak to an MU expert as well, which generally gets back to me. So any number of ways you can go ahead and get a hold of us. So question number one. Problem list in the emergency department. Can you comment on the ED physician role in this? So a couple of things. So problem list in and of itself for stage 2 is eliminated as an individual measure, but again, you still need to have a problem list documented on the patient. CMS does not define who has to enter the problem list, whether it be entered by a nurse or by a physician or by a tech or by the patient themselves. As long as the system actually keeps or has a problem list entry on that patient, each unique patient, at least one entry, then you're good to go. In our system, and I can speak to that specifically. Both the nurse and physician can contribute to the problem list. The final diagnosis populates the problem list most of the time as well. The problem list can also be populated by some of the circles and backslashes in our product that come as a normal part of your clinical documentation. So inevitably, nearly 100% of patients ends up with a problem list, whether anyone interacts with that directly or not. But strictly speaking, as long as a problem gets in the problem list, it doesn't matter who entered it or how it got there, it can get there. In stage 2, and I'll go into this in much more detail in the interoperability webinar, all the vendors who certified for med reconciliation really certified to clinical information reconciliation, which is the ability to round-trip share meds, allergies, and problem lists as discrete codified data in Consolidated CDA, and be able to bring the data in from an external CDA into their system and have it reconciled and incorporated as real data in their system. From a workflow perspective, I think this would more likely envision this being done by a nurse than a physician, but it could be done by either. There really isn't a limitation as to who can do it. Since problem list in stage 1 is a unique patient measure too, if you're still in stage 1, it doesn't matter whether it's done in the ED or the inpatient environment. You don't have to keep those two in sync. Obviously, there's reasons to look to do that, but as long as there's a single problem list entry, you're good to go. Stage 2, do verbal orders entered by an RN count as good CPOE for MU? And that is absolutely not. There are two real issues. Verbal orders and written orders are the two that will not meet the requirement for CPOE, and that is CMS has very specifically said that they do not want the order to have the ability to be acted upon prior to being entered in CPOE. Verbal orders obviously are designed to do exactly that, and verbal orders have a place. They're supported by Joint Commission in limited circumstances, and so those verbal orders would not count for meaningful use. However, they should be fairly limited to really emergent and resuscitative circumstances, whether that's the ED or the floor. Written orders also do not count, so if you've got physicians writing on paper and then someone transcribing it into a CPOE system, those do not count for meaningful use either. Another question posed was, stage 2, I thought stage 2 starts in 2014. Don't I have to do stage 2 in 2014? And this is a fairly common misconception. Although stage 2 does begin October 1, 2014 at the earliest, all hospitals are given 2 years of stage 1 before they are required to meet stage 2. So after your first year of successful attestation for stage 1, then you will move on to stage 2. So if you've not already met or in the process of finishing up your second year or more of stage 1, then no, you do not start stage 2 this fall. You actually do start, you continue stage 1. Everybody thoroughly confused at this point? I do not have any more questions on the question pane at this point. Anybody who does have one, I'll give you another minute or two to go ahead and type those in. And in the meantime, I'll give you my email address in case you didn't capture it before. Feel free to email me. It's B Hitchock, HITCHCOCK @TSystem, TSYSTEM.com. Please be careful not to do tsystems.com. That's T-Mobile or Deutsche Telekom. And believe it or not, there is a B Hitchock that works there as well. We do send each other the appropriate emails from time to time. Forward them on. With no more questions, I want to thank everybody again. I hope I didn't lull you all to sleep. All those remaining attendees, thank you very, very much for spending some time. I hope that you'll join in future webinars. We'll be covering a lot of things that we haven't covered in past webinars in those, and some that are very, very specific to EV, but others are going to do a deep dive into meaningful use and the meaningful use measures, really regardless of the systems that are using. So I hope you find those useful. Thanks, and look forward to getting you here in a couple of weeks for the next webinar.
Thank you, Dr. Bob. So as I mentioned, I will be sending out the recording after this session for you to review or to pass on to any colleagues who are unable to attend. And if you have any questions, feel free to email either myself or Dr.